started here. Yeah. It's on live. Yeah. Sir, Karunakaran sir, ipo theriyum.
Okay. So ரெண்டுத்தையுமே ஆன்ல வெச்சுக்கோ சார் இப்போ.
ஆமா சார், நீங்க இல்லனா ஒண்ணு கூட நீங்க அது பண்ணிடலாம் சார், நீங்க நோ இஷ்யூஸ். உங்களுக்கு எது கம்ஃபர்ட்டபிளா இருக்கோ நீங்க பண்ணிக்கோங்க.
சரி, இது பாட்டுக்கு இருக்கட்டும் சார்.
அது இருக்கட்டும் சார், ஒன்றும் ப்ராப்ளம் இல்லை. So that you can see all of us in the laptop and we can see you in your mobile. Shall we start, sir? Thanapan sir, shall we start? Thanapan is also there. Sir, satellite English, sir. Karunakaran sir, you are
yeah, please go ahead, sir. Go ahead.
Yes, sir. Yes, sir. Thank you. So very good evening to all of us. I mean, all the postgraduates and the faculty. Today, actually, this will be the last session in spine, sir. So that is the plan, because we almost covered spine. But today, I think it will be the most interesting session in spine also, because we have three very extremely good faculties and personalities today with us, and very, very senior persons who have tons of experience in spine surgery. So it is an honor for me to introduce the three faculty members. So first, I would like to know, about Dr. Karunakaran. Karunakaran sir is one of very, very senior faculties who was also part of the spine unit in Madras Medical College. Only recently he left his teaching and he joined as the director of advanced spine surgery in Gleneagles Global. Sir has got a huge number of papers, fellowships, tons of experience, which I might not be able to, all the three of you have it. So it's very difficult for me to, read everything. So sir is a very, very senior person. He's done a lot of fuss in Tamil Nadu. I think he's brought up the, under local anesthesia, minimally invasive spine surgery, and, so on and so forth. He's got tons of things, which I'm sorry, sir, I'm not able to read in this forum. And
thank you very much.
So we immensely thank him. We immensely thank him for having consented for being the expert panelist here, and his experience will definitely help the postgraduates to approach a spine case very easily. And we have another speaker, Dr. Thirumalai Murugan, very soft-spoken person, multifaceted orthopedic surgeon. He operates spine, he operates arthroplasty, complex trauma, acetabulum, trauma, you name everything, I think he operates. And so very happy to have you, sir. And son of soil in Madurai Medical College. And his undergraduation, post-graduation, diploma, MS Ortho, assistant professor, associate professor, everything in Madurai Medical College. So, and he again has got done a lot of fellowships, submitted a lot of international papers, and has been a part of the spine for a very long time. So we welcome you, sir, for this program. And we have Dr. Rishi Kanna, another very known person in spine, and from Ganga Hospital. And I've seen he's been a part of, he's been author of 4 books, 43 chapters in different books, and he's national award, so many awards he's got. And so I cannot name everything. Basic Research Award in 2011, Professor A. Subramaniam Best Research Award in 2009, R.C. Rallan, I think the very prestigious R.C. Rallan Gold Medal in 2012, and he is also member of so many editorial boards like European Spine Journal, and also reviewer of ESJ, ASJ, and we can go on. So thank you, sir, and thank you, sir, for having joined us. So all three eminent faculties today, we have spine surgery. I think the PGs will have wonderful experience to interact with you. So without much delay, I invite Professor Karunakaran to start the program, and Dr. Thirumalai and Dr. Rishi Kanna to proceed. Thank you, sir.
Thank you, Professor Thirumalai. We'll straight away thank you from from the bottom of the heart for this opportunity. And I invite Dr. Rishi with his case presentation. So please, Dr. Rishi, please start.
Yes. So while I share my screen, I thank TNOA and Dr. Thirumalai and entire faculty members for having invited me. And so I'll be presenting a case of a child who presents with back pain. So it is a very unique situation. And so I'll go by an algorithmic approach, like how to examine the child clinically, what are the things that needs to be asked in the history, how do we rule out the multiple diseases that affect the child in the spine. So this is the history. The patient is a 10-year-old boy. So the informant is the mother. They are from a low socioeconomic status. And the presenting complaint includes, in the chronological order, pain in the upper back region. So the pain is present in the thoracic region, in the upper thoracic region for the past 3 months. Initially, the pain is on and off, but over a period of 15 to 20 days, the pain has increased in intensity. And in the last 15 to 20 days, the mother has noted a deformity in the upper back, the same region where the child complains of pain. The mother has noted a deformity. And in the last week to 10 days time, the child is having increasing difficulty in walking. So 3 presenting complaints. One is pain in the upper back region, deformity in the upper back, and the most recent problem for the patient is the difficulty in walking for the last 10 days. Let me ask Vignesh. So what is the thing that goes in your mind when you see a 10-year-old boy who presents with these 3 presenting complaints?
Sir, any history of trauma, sir?
There is no history of trauma.
We can rule out tuberculosis spine, sir.
Right, very good. So, so he has straight away thinks that this could be a case of a spinal infection. And before we point to one particular diagnosis, we need to rule out the common reasons why somebody will get a back pain. So these are the common conditions, like we can have a degenerative disease or a congenital problem of the spine, a trauma or a tumor in the spine, or an infection can also present like this. So obviously, the patient being a child, so we have ruled out degenerative conditions. How about any congenital diseases? Does any congenital problem of the spine can present with pain, deformity, and walking disability? Will you keep it in your differential diagnosis, or would you like to rule it out straight away?
You can keep it, sir.
You can keep it, right? That's good. So we'll keep it congenital disease, and since there is no typical history of trauma, we will rule out trauma. How about tumor? So any tumor in the spine, can it present like that?
Yes, sir.
Right, okay. So, with this stage, we will have these 3 possible diagnoses. So we'll have a congenital problem of the spine, an infection of the spine, or a spinal tumor as a differential diagnosis. So we'll go by the second important history, is a deformity in the back. So if the child is having a deformity, which is of a reasonably short duration, so the mother has noticed the deformity for the last 1 month. So if you consider tumors, so tumors usually will have for a tumor to produce a deformity in the child, it should be a really malignant tumor. So they will have, the pain will be very painful, and for it to cause deformity is very rare. So tumor in the spine causing a deformity is very rare. So if the child is present only with pain and neurological deficit, you should have tumor as a possibility till the last evaluation is done. Whereas when you have deformity in the history as a presenting complaint, then a spinal tumor is an unlikely possibility. So that we will rule out. So now we'll have only 2 possible possibilities. Either it could be a congenital problem of the spine or spinal infection. And we go next, we take some history to differentiate between possible spinal infection and congenital disease. So what are the histories that we take?
History of fever. History of fever with the night cries.
Right. Yeah. So we put a broad terminology for that. So that's called as a the child may or may not have fever, loss of weight, loss of appetite, evening rise of temperature. And if the pain is quite severe, the child can present with night cries. So these are some of the constitutional symptoms a child can have. And other important history one should elicit is infections elsewhere in the body. So a child who is having a septic arthritis or a recent history of pneumonia can also develop a pyogenic infection, or in the recent past treated for a tuberculosis also should be part of the leading history. So how will you rule out the congenital disease? So what are the type of questions that we will ask in this to the mother particularly to rule out congenital disease as a possibility?
Noticed since birth.
Right, exactly. So there is one caveat to this. So one should understand that when we talk about a congenital disease, so typically we are thinking about a congenital scoliosis or a kyphosis. So a deformity in the spine at birth. But these deformities, most of them will not be evident at birth. So once the child starts walking around 1 to 2 years of age, then only the deformity becomes progressive by the first growth spurt around 4 to 5 years of age, right? So even though we term it as congenital, most of the for the parents to be obvious, then it takes at least 5 to 6 years for the child to become, right. So we get a general history about birth history, perinatal history, whether the child had any problems in the immediate perinatal period, other childhood illnesses, because you should have heard about the term Vater syndrome. So usually vertebral anomalies, they don't occur isolated. They are usually accompanied with some of the congenital problems of the gastrointestinal tract or a renal tract, like that, right? And if they have noticed the deformity, you should also get a history regarding the progression of the deformity. So in this patient, it is for only 15 days. So this is unlikely again to be a congenital problem, more likely to be infection based on the short duration of the deformity. The other leading questions in this patient, he tells there is no history of fever, no constitutional symptoms, there is no trauma, no particular history related to any childhood illnesses. So would you ask any history related to the presenting complaints apart from these queries?
History of contact with the TB, sir.
So that will be in the you can ask in the present history, but it will be a separate contact history will be a separate thing. So we discussed about the pain, we discussed about the deformity. So there is one more thing the patient presented with, isn't it? What is the third problem? So the child also presented with neurological deficit. So would you like to ask some more history related to the neurological deficit?
It's progressive or
static. So yeah, so there are some questions which you need to ask related to the neurological deficit. So we basically divide it into motor problems, a sensory problem, or a global affliction, like whether the bladder and bowel are also affected. So in motor, you should ask whether the upper limbs are also affected, because many times when the parent presents with walking disability, they may not be able to giving much significance to the upper limb involvement also. So basic problem could be in the cervical spine, where the cervical spinal cord also is affected. Second thing is to ask about the sensory involvement. So the parent may not know that paresthesia, the numbness which the child has, importance to this particular problem. So this is important to also assess the level of the lesion based on the history itself. So the child, if the child complains of numbness, which part of the body is affected by the numbness? It is below the chest, or below the nipples, below the xiphisternum, or below the umbilicus. So based on this only, we'll be able to decide which region of the spinal cord is affected. By we will able to decipher which vertebra is particularly affected, right? So we also get history about the bladder bowel. So bladder also the patient may not tell, but you should specifically ask, is there any sense of incomplete evacuation of the bladder or bowel, right? And also we ask questions related to the deformity. So as you told, it should be about the progression, whether it is a painful deformity or a painless deformity. This particular patient, so the upper limbs are normal for the child. He is able to eat, write, everything. And the lower limbs are affected. And the weakness is quite extensive. He uses a walker to only walk a few steps. He's not able to walk further. And the numbness is present from below the zygmoid process. So above the zygmoid process, everything is fine. So what information do we get out of it?
involvement is in the dorsal spine, sir.
In the thoracic spine. So which level of the spinal cord is affected by this at this level?
Below D7.
Yeah. So we should say the thoracic spinal cord at the level of T7 is affected. So you should not say T7 vertebra, because there is discrepancy between the position of the vertebra and the spinal cord. So from the history, we are able to identify the T7 region of the spinal cord is the one which is maximally affected in this particular patient. But for this, you have to remember this table. So this is a very important one. So as we know that the there is discrepancy in the length of the spinal cord versus the vertebral column. So at the upper cervical spine, both the vertebral and cord levels are at the same level. So from C5 to T1, you have to add 1. So the T1 vertebra will correspond to T2 level of the spinal cord. From T2 to T5, the upper thoracic spine, we add 2. So the mid thoracic spine, we add 3. From T10 to T12 levels, we have the lumbar region of the spinal cord. And at the L1, we have the conus medullaris, which controls the S1 to S4 zones. And from L2 to S2 is the cauda equina. So is it clear? So you should be able to remember this. So in this particular patient, our level is around T7. So T3 to T7 means, so we have to minus 2 to identify which vertebra is affected. So from the clinical examination, we presume that the patient is having a problem at the level of the T5 vertebra, right? So for the completion, as we discussed earlier, so we should ask history relating to the past medical treatment, any personal history, contact history with any other members of the family having a possibility of tuberculosis. And if he has been taken any treatment, that also should be documented. So from the summary, based on the history, we have a 10-year-old boy from a low socioeconomic status, was previously healthy, no childhood problem, reasonably subacute onset. So all symptoms, everything started and worsened in the last 3 months. So we are looking at a problem which is subacute, and he has a partial neurological deficit. The motor level is below L2, because above L2, we may not be able to check the power. So the hips are weak from below, whereas the sensory level is at T7. So based on that, we assume that the vertebral level will be at T5. His bladder and bowel is luckily intact. And so our probable diagnosis is most likely it is an infective pathology of the spine, which has resulted in this problems, pain, deformity, and neurological deficit. But still, we won't be able to exclude congenital problems altogether, because there is no history related to infection, like a fever or a constitutional symptom is there. So we'll keep our mind open. So in the general examination, we have to look specifically for any features of a chronic infection like anemia, icterus, generalized lymphadenopathy. And in the abdomen examination also, you should be able to see whether there is any liver and spleen enlargement in the clinical examination. Respiratory system, you have to auscultate for crepitations and respiratory rate. And if there is a chronic possibility of a chronic infection, you have to look for clubbing in this patient. And
excuse me, Dr. Rishi.
Yes, sir.
Yeah, just going back to the previous slide, I'd like to ask the postgraduates, in this, the relevance of examining the liver, spleen, what is that which will go through their mind? And why they have to look for liver and spleen? Just if somebody can answer, I'll be happy.
Yeah. Vignesh or Manikandan, one of you can answer it.
Why is that you have to look for any spleen or liver? What goes through your mind when somebody says you have to look for liver or spleen?
In adult cases.
In adult, yeah.
To rule out secondary spine, something. Yeah.
Okay. Okay.
In this particular patient, yeah.
With relevance to this child, if you have to look for liver and spleen, what is that you should look for?
Typhoid and pyogenic.
Sorry?
To rule out any pyogenic infection.
Pyogenic, okay. What is that in pyogenic you expect?
Typhoid, like that.
Okay. Yeah. If there's anybody got a specific answer, you can come up with the answers. Otherwise, I'll ask Dr. Rishi to give the explanation. Okay, please, Dr. Rishi, you can please explain.
So, in this particular child, whenever you have a possibility of a chronic infection, so the liver and the spleen can be enlarged in this patient. So that's why we examine the abdomen to look for hepatosplenomegaly, right? So if it is present and if you are missed in the clinical examination, then it is a problem in the exams, right?
Yeah. Thanks.
Yeah. So since we have kept congenital diseases as a possibility in this patient, so you should examine the patient in general, look for features of a congenital problem like a facial dysmorphism, the presence of a torticollis, because we are thinking a problem something in the upper thoracic region. Look for features of a Klippel-Feil syndrome. Look at the hands and fingers for any features of orthokyphosis or a ligamentous laxity. And coming to the local examination of the spine in particular, so every spine examination almost always starts with the gait examination. But we should make sure that since these patients have the possibility of neurological deficit, they should have a power of at least above grade 3 to look for a gait in this patient. Because if they have a power less than 3 in the lower limbs, there is a possibility that they may fall down if they are unsupported. So while you do the clinical examination, make sure that the patient is able to lift his leg up in the air at least to a power of 3. Then only make the patient walk. Otherwise, if the power is less and the patient falls down, it's a problem. So if the patient is able to walk, then you should mark these observations in the gait. So whether the patient is able to walk assisted or unassisted, whether it is a bipedal walk, whether it is antalgic or pain-free, whether it is a spastic or a flaccid gait. So this is one of other patients who is having, this is not the exact same patients, the other patient who has a similar problem in the spine with the gait. So Manikandan, can you have a look at the gait and say what type of gait is the patient is having? It's a very, very classical gait which you should not forget, right? Right. Again, and antalgic is usually, so it will be on one side. See, both the sides, he's walking like a machine. He's walking
stiff gait.
It's a stiff gait. So it is a classical myelopathy gait. So he's walking unassisted, bipedal, but it is a spastic gait, right? And it is a bilateral spasticity. So if it is a unilateral spasticity, we think in terms of a stroke or a hemiplegia, whereas if it is a bilateral spastic gait, then we think about spasticity in terms of myelopathy, right? Coming to the local examination of the spine, so we examine the patient from behind, we examine the patient, that's the first thing we do. We also examine the patient from the front and side, so to look for other things. Third thing is to examine the patient in the supine posture, and the fourth one is the lying prone. So among these, examining the patient from behind and the supine examination are the most important in spine. So when we see the patient from behind, these are the things which we pay attention to. We see the attitude of the patient, whether the patient is standing straight or with a scoliosis or a sciatic list. And then we check about the position of the head, whether the head is centered between the scapula, whether the head is centered exactly in line with the pelvic region, whether both the shoulders are at the same level, whether the scapula are at the same level, and is there any prominence of rib hump, right? And also look for any swellings, sinus, or any skin changes. So in this patient, Vignesh, what exactly is the patient is having? What abnormalities are you seeing?
Scoliosis.
So you should say that the right shoulder is at a higher level, the right scapula is at a higher level, and we are able to say based on this the patient is having a scoliosis, right?
Yes.
But in that particular patient which we had presented, so that patient is having very significant pain, and if you are not able to make the patient sit up comfortably, then don't present the findings in the sitting or the standing posture. You can present the findings in the supine and lateral examination. Right. So since we have kept congenital problems as a possibility, you should also tell about neurocutaneous markers, whether you are able to see a tuft of hair at the back, any features of a nevus or a dimple or a caphioles parts. So this problem of a pain, rapid onset deformity, and neurological deficit can happen in a condition called neurofibromatosis of the spine. So if the patient is having type 2 neurofibromatosis, they can have multiple caphioles parts, and that deformity will be a rapidly progressive deformity. So examine the patient completely to find out any caphioles parts. So rest of the thing is only in a painless deformity. So this patient is having a painful deformity, so we don't do this test. But if the patient is having a painless deformity, you have to do this Adams forward bending test to see where exactly is the deformity in the spine. So that completes the examination from behind. You observe the patient from the side. So you look for how much is the cervical lordosis, whether the thoracic kyphosis has increased or not, how much is the lumbar lordosis, is this obliterated by a paraspinal spasm or is it exaggerated? And you check the overall sagittal balance in the inspection. Then you do a palpation. So in palpation, we basically confirm all the inspection findings, and we typically feel for the spinous process, whether the spinous processes are all well aligned. So in this patient, we are thinking about in terms of a deformity in the upper back, possibility to tuberculosis. So the usual deformity in tuberculosis, spinal tuberculosis, is a kyphosis deformity. So when you palpate for the spinous process in this particular patient, you should be able to feel whether it is a single prominence, whether it is a one vertebral collapse, what we call as a knuckle deformity, or it is a sharp angular deformity because of 2 or 3 adjacent vertebra involvement, what we call as a gibbous deformity, or a global involvement of multiple adjacent vertebra, so which is like a rounded kyphosis, right? So this is a video how to check for rotatory tenderness in the spine. So this patient, we feel for all the spinous process and rotate the spinous process to look for any tenderness. So the lower video is the one where we can see is the thumping tenderness or a deep tenderness. So whenever there is a problem in the anterior part of the spine, the vertebral body, and we want to elicit tenderness in this patient, we do a thumping tenderness. So superficial tenderness in the spine is a rare observation. It is a very uncommon. It indicates the patient could be a malignant patient, or it could be a superficial skin problem. Whereas problems per se that happen in the spine will have only 2 types of tenderness. Either it is a rotatory tenderness or a tenderness elicited by deep thumping.
Yeah, Dr. Rishi, in this context, can one of the PG tell us what is the relevance of rotating the spine and eliciting tenderness versus thumping the tenderness? What is that? What do you infer by doing a rotatory tenderness, and what do you infer by doing a thumping tenderness?
So, rotatory tenderness is to check any lesion in the anterior part of the vertebra, sir.
Okay.
So,
and what will be the thumping tenderness indication?
The thumping tenderness is to rule out any lesion in the posterior elements of the vertebra.
Yeah, see,
any lesion in the posterior elements.
Even if you touch the post element, let us say the spinous process is infected or there is a pathology, even by putting a finger, you're going to elicit tenderness, correct?
Yes, sir.
So even a posterior tenderness, when you run your finger, you're going to elicit, to say some extent, this a post element tenderness. But when you do a thumping, it has to be a deep seated. So to elicit a deep seated pathology, you need a thumping force. Okay, but whereas in a rotatory, where there is when you rotate, you can elicit some sort of a instability related pain. Okay. If there is any point which anybody would like to add, please, Dr. Rishi, you can add.
Yeah. So typically in a patient, for example, you are seeing a patient with a spondylolisthesis and you want to elicit tenderness. So what you do is the rotate tenderness. So you feel for the spinous process, you rotate the spinous process, thereby when the rotation happens, it tries to rotate the spine anteriorly also, and thereby the pain will be elicited in that particular patient. Whereas the thumping tenderness is sort of a deep tenderness, a patient who is having an early infection in the spine or an early tumor in the spine in the anterior part of the vertebra, that is where you get a thumping tenderness.
Yeah, please proceed.
So the third part of the examination, you do movements and measurements. Basically, you check for the range of motion in the spine, but it should be done only if the patient is having a painless deformity in the spine. Whereas if the spine is very painful to movements, especially in a patient with a neurological deficit, you should not check for the movements of the spine because we may be exacerbating the instability present in the spine. Based on this history, the present patient has the following observation. So we couldn't check the gait because he's having weakness in the lower limbs. And when he is sitting in the bed, he sits with a kyphosis. So it is a gentle rounded kyphosis present in the upper thoracic spine from T2 to T7. So starting from the prominence of the upper thoracic spine till the scapula, he's having a deformity. And both the shoulders are at the same level, which indicates it is only a kyphotic deformity and not a kyphoscoliotic deformity. And we are able to elicit tenderness by rotating the spinous process in this patient. And we didn't check for the movements of the spine because of the neurological deficit. Coming to the crux of the examination. So whenever you have a patient with spinal deformity and neurological deficit, all your scoring points are going to be in the neurological examination, how you are able to elicit a proper neurological. First part is the motor examination. So in the motor, you have to tell three things. One is the tone of the muscles affected. Second is the bulk of the muscles. And third is the power. So tone, you move the joints passively and see whether it is a normal tone of the muscles or you are feeling hypertonia or hypotonia. So in this particular patient, Vignesh, what do you expect? You expect hypertonia or hypotonia?
Hypertonia, sir. UMN type.
Exactly. So it is, we are suspecting the spinal cord affliction. So it should be a hypertonia present. And normal muscle bulk because the symptoms are present only for a short duration of neurologic deficit. And third thing is to check for the powers. So we don't check each and every muscle of the upper and lower limbs. We follow the key muscle concept. So the key muscle typically in the upper limb, for the C5, we check the elbow flexors or the shoulder abductors. For the C6, we check the wrist extensors. For C7, we check the elbow extensors. For C81, finger flexion and abduction. Similarly, for the lower limbs, L2, L3, and L4 and L5S1, we have the hip flexors, knee extensors, ankle dorsiflexors, long toe, distal extensors, and ankle plantar flexors. So we check all these muscles bilaterally, upper limbs and lower limbs, and then document the power based on the MRC grading from 1 to 5. Right? Next thing is to check the sensation. So since you noted in the motor thing, we are not able to examine any of the muscle groups between T2 to L1. So for assessing any spinal cord affliction between T2 to L1, we rely entirely on the sensory examination. So that's why sensory examination is very important. So we check with the pinprick, cotton wisp also to check for light sensation and deep painful sensation. For every region of the spinal cord, spinal segment, we have a special key zone. So you memorize that zone and then check that particular region to see how the sensation is present and then compare with the opposite side. So for the thoracic region, we don't have a muscle power assessment. So you have to rely on the thoracic sensory examination. And for each level, we have the specific anatomical landmarks like the nipple line, the xiphoid process, the umbilicus, as well as the groin region, T4 to T12. Third part of the neurological examination is the eliciting of the deep tendon reflexes. So we have 5 deep tendon reflexes. The scapulohumeral reflex is performed only in patients who is having a cervical compressive myelopathy, whereas the rest 5 deep tendon reflexes have to be elicited and checked in all the patients. So each deep tendon reflex has a particular spinal segment allotted to it. Biceps means 5-6, triceps is C7, supinator again 5-6, knee jerk is for L4 and ankle jerk for S1. So based on the response you get, you are able to localize the lesion. So this is very important, especially in patients who have a cervical problem. So this reflex will be exaggerated if there is a lesion above the level of the segment which is affected. For example, if the triceps is brisk or exaggerated, so you assume that there is a lesion above C7. So in this particular patient whom we have discussed so far, you would expect all the 3, upper limb jugs to be normal. So the biceps will be normal, triceps will be normal. Whereas since there is a thoracic level lesion, both the knee and the ankle jugs will be brisk and exaggerated, right? So these superficial reflexes, we check the abdominal, cremaster and plantar response. The plantar response is the most important in this patient. So Manikandan, what exactly will be the plantar response in this particular patient? So what do you expect?
Extensor reflex.
The reflex should be present bilaterally, indicating a UMN problem, right? So no examination of the spine is complete without doing a perectal examination. And in the perectal examination, you have to check for 5 things, right? So you remember your hand. So you're putting your finger inside the patient. So you have to check for the perianal sensation around the S3-4 dermatomes. Check anal wink. Anal wink is tested using a small pinprick. By pricking around the anal skin. There should be involuntary contraction of the anal sphincter, external anal sphincter. Then you put your finger inside the external sphincter and check for the resting anal tone and ask the patient to have a voluntary anal contraction, and finally check for bulbocavernoid reflex. So all these 5 things should be documented in your case sheet when you're doing a neurological examination. So in this patient, this neurological examination is as noted here. The upper limbs are completely normal. Lower limb, the power is between grade 2-3 in all the segments. Sensation is T7 level at the level of the Ziegfeld process. Upper limb jugs are normal. Knee and ankle jugs are exaggerated. Plantar was typically extensor. So at the end of this presentation, so the examiner will ask you to summarize the findings. So this is how we summarize the important positive findings and.
Excuse me, Dr. Rishi, just a quick question in this. Till what age would somebody say this upgoing plantar is normal? Dr. Vignesh?
Vignesh, yeah.
If somebody, if our Manikandan knows, you can still answer. Till what age you would say that plantar upgoing is normal? You can expect. If the child was, let us say, still younger, you would say this is an upgoing plantar is normal. I think it's 4 years, till 4 years, the upgoing plantar is normal. If I'm correct, yeah.
Yes, sir. So plantar response could be a normal response in the child, and up to 4 to 5 years of age, it doesn't have differentiating capacity. But beyond 5 years, once all the reflexes are well developed, the normal response should be a flexor response. So beyond now the child is 10 years in this particular patient. So it is a plantar response indicates there is a upper motor neuron involvement of the spine. So this is how you tabulate. So the age of the child, subacute onset of pain and deformity in the upper back, reasonably rapid onset weakness of the lower limbs. So there is a painful kyphosis in the upper thoracic spine. No findings or history to suggest a congenital problem. The lower limbs are weak and they are spastic. So the sensory level is at T7 and other human signs are also present. So my diagnosis will be like a child with an upper thoracic kyphosis with partial neurological deficit, probably infective due to tuberculosis, because tuberculosis is common in our country, and this presentation is a subacute onset. If you are suspecting a pyogenic infection, it should be a rapidly progressive, and child will have fever and acute acute presentation of symptoms. It won't be like a symptom duration for 3 months. So based on T7 level of the sensory level, we assume that the vertebral level that is affected in this particular patient is T5, right? So next we get the X-ray of the patient. That's a standard protocol. So Vignesh, can you comment on the radiographs? Anything you see abnormal?
An X-ray of a skeletally immature patient showing a dorsal spine.
Dr. Vignesh, you told skeletally mature.
Immature, sir.
So what should it be now? What should the answer be? It's not mature, right?
Yes, sir.
So the routine word mature will not stand good here.
Yes, I said immature, sir.
Yeah, it's not attained the full growth, no? So
yes,
yeah, please go ahead.
Okay. skeletal image for a patient showing a dorsal spine with
So it's not only the dorsal spine, you can see the lower part of the most of the subaxial cervical spine as well as the thoracic spine, right?
Yes, sir.
Yeah.
Showing vertebral body collapse at around D5 vertebra.
So are we discussing the AP or the lateral views?
Showing a lateral view, sir.
Lateral. So anything abnormal you see in the AP view? What will you see in the AP view? Anything been related to, for example, in this patient we are suspecting tuberculosis. So anything would you?
Vertebral body height.
Right. So basically, you look for the alignment of the spine. That's the first thing to check in the AP view, whether you are able to see all the spinous process in alignment, right? And you are able to see all the pedicles in alignment. So here you can see, we can see the pedicles clearly in the upper level also. We can see clearly, but right from T5 to T7, we are not able to see clearly. That's the one observation. Second observation, you can see some faint shadows here, soft tissue shadows.
Okay, sir.
Over here also, you can see here. Yeah. So you don't see this bulge in a. This is the cardiac shadow. You can see the cardiac shadow. Whereas you can see another big round here. So there is an increased soft tissue shadow present on the right side in the paravertebral region. So this is that we are observing in this AP view. Yeah, come to the lateral view. Lateral view, what did you see?
Lateral view on the D5 vertebral body height is collapses.
So how do you know this is D5? We have assumed it is D5, doesn't mean that it has to be fifth thoracic vertebra, isn't it? So what I say is either you have to count from the top, but even then we may not be able to see clearly. The upper thoracic spine is overlapped by the scapula and sometimes the humerus also. So it is a crowded region of the vertebra because of the ribs overlapping also. So we're not able to see clearly. So what you should say is that there is a collapse of vertebra noted in the upper thoracic region, right? And it needs a further evaluation with a MRI or a CT scan to see how much is really affected. Understood? Right. So Dr. Karunakaran sir, would you like to add anything?
I think the other good way of looking at is the AP view, where the ribs are quite useful in counting. And
Yes,
you look for the rib crowding in these areas, it will also tell where exactly is the pathology. So that is another way of counting is what I thought.
So like sir told, so this is 1, so this is 2, this is 3, this is 4, this is 5. So you can see compared to the upper 3, so in that mid thoracic region, the T5 to T7 region, you can see some crowding of the ribs. So that can also indicate a surrogate marker of a collapse of the vertebra at that level, right? So the patient needs further investigation. So would you like to do a CT or MRI next?
Can do MRI.
Right. So why MRI?
To rule out cord involvement.
Right. Yeah. So if it is only a painful spine or a deformity, then you can say CT also. But in this situation, MRI is very mandatory because the patient is having neurological deficit. We see cord status also, and it also shows the abscesses also very well since we are suspecting tuberculosis, right? Right. So that's the MRI for you. Yeah. Can you please read the MRI?
T2 weighted MRI showing a dorsal spine with hyperintense lesion around the upper dorsal spine.
So first thing in the whole spine section is the main purpose is to see is there any lesions elsewhere in the spine. So that has been ruled out. So main region affected is the upper thoracic spine. So in this picture, what are things you see from anterior to posterior? What are abnormalities you are seeing?
The anterior longitudinal ligament is compressed.
Yeah, the anterior longitudinal ligament is this one that has been elevated. So what is happening here? So this region is this is a T2 MRI. So we are seeing a hyper intense signal. So that probably indicates a abscess,
Yes, sir.
right?
Yes,
So
sir.
next, what is happening in the vertebra?
There is a vertebral body collapse.
So actually vertebra is not there. So we are not able to see the vertebra here. So we are seeing one vertebra here clearly, another vertebra here. Here the vertebra is completely destroyed. So it is not collapse and complete destruction of anterior vertebral body over here. And then next, what are we seeing here behind?
Posterior longitudinal ligament, and then spinal cord.
Yeah, between the post-longitudinal ligament and the spinal cord, what is this thing?
Ligamentum.
No, the posterior longitudinal ligament has been elevated by the abscess. So this is an epidural abscess, right? So there is a prevertebral abscess. There is complete vertebral destruction. There is a there is an epidural abscess, and there is cord compression. The cord has been tented by the vertebra, by the abscess, right? So this is the vertebral destruction, abscess. You can see the deformity behind. So there is a smooth deformity at the upper thoracic spine. So what you see in this is the what image is this? Is this axial, coronal, or sagittal image? Yeah, Vignesh, fast. So this is the coronal image through the spine and the lungs. So this is the lungs. So this is the left lung. This is the right lung, right? And this is the vertebra in the middle. And this round thing, what we are seeing here is the spinal cord, right? So what is this round thing which you are seeing inside the right lung?
Abscess.
Yeah, so this was the abscess which we are seeing in the X-rays also. In the X-ray, we saw a semicircular shadow in the right part of the lung. That is what is seen. There is the abscess that is seen in that X-ray, right? And this is the axial image. So axial image, you can see there is extensive abscess formation, paravertebral region in the sides, in the front, within the spinal cord, around the spinal canal, around the spinal cord. So this is spinal cord which has been compressed by the abscess formation, right? So now our diagnosis is pretty much clear. So you don't get this picture in a congenital deformity, and you don't get this picture in patients with pyogenic infection also. This is a classical presentation of a spinal tuberculosis. Multiple confluent vertebra has been affected, extensive abscess formation in the front, sides, and in the epidural space. So these are all characteristic MRI features of MRI of spinal tuberculosis. So how do you treat this patient? So
First middle path regimen start with ATT. And then if on continuation of treatment, if there is a progression of the neurological deficit or no living symptoms, we can go for surgery.
Right. So you want to treat the patient by starting anti-tubercular treatment, right? Manikandan,
Sure.
what do you think? Should we start on medications, or does the patient need a surgery?
First, we start ATT, sir. The deformity is severe, after starting ATT, we start a surgery.
Right. So you think that if the deformity worsens, the patient will need a surgery. So to both of you, I'll ask a question. What do you mean by spine at risk signs?
There are 4 signs, sir. Facet subluxation, lateral translation, the topping of one vertebra over the other, the retropression of the abscess over the.
Right. Okay. So if 2 signs are present in a patient, so what will happen if
the deformity worsens, sir? So it will go for kyphos, and so surgery is indicated in this case.
Indicated. So does this patient have spine at risk signs? So did you look for in the X-rays or the MRI whether the patient had spinatus sign? So if it is like a thoracolumbar spine, it is easy to see in the radiograph the facet is subluxing where there is any retropulsion. But in the upper thoracic spine, the MRI will not show the extent of bony problem. So you need a CT scan in this child, right? So do you see anything? So this is the CT of the child. So I'll put arrow marks to favor time, right? So what is this sign? Which spinatus sign is this? So this is a posterior retropulsion. So you along the intact vertebra above and below, and at the point where the lines cross, there is a retropulsion of bone behind, then it indicates there is a spinatus sign.
Yes, sir.
And this is one more. So this is the lower facet joint. So the normal facet joint, you can see both the facet joints are in approximation. But as you can see here, they are trying to jump over each other. Understood? So this indicates that there are subluxation and posterior retropulsion. So two spinatus signs are there. So if you treat this patient conservatively with only bed rest and antitubercular treatment, so this anterior vertebra has to heal. So if it has to heal completely, this bone has to slip further and further. So the child will end up in having a buckling collapse of the spine later on. Even though the acute neurological deficit will recover with antitubercular treatment, later the child will develop a internal gibbous later on and present with late onset neurological deficit. Understood? So this is a child who needs a surgical fixation and not a conservative line of treatment. We can't start middle path regimen and then switch over to surgery if the deformity worsens. At this stage, if you treat this patient, it is easy to do surgical intervention, right? So there are two spinatus signs positive. So along with that thing, we do the basic blood investigation. And during the surgery, we send for TB culture and gene expert test, very, very important. So whatever debridement we are doing, we send it for TB culture test. And antitubercular treatment has to be started from the next day of surgery as early as possible. So this is the biopsy of the patient. So this is a TB culture test. So you can see that culture has grown, Mycobacterium tuberculosis. DNA is also positive. And all the primary drugs and secondary drugs have been tested, and there is no drug resistance in this patient. That is the culture report of the patient. So this is the surgery that has been done, right? So since there is two vertebrae.
Hello, there is a transmission problem, I think. We cannot hear Dr. Rishi speaking.
Hello?
Yeah, tell me, Rishi.
Yes, right. Hello?
Yes, you are audible, sir. You proceed.
Right, fine. So we have fixed the spine at least 4 levels above and 3 levels below, correcting the deformity. And anteriorly, we have packed bone graft in the front, right? So the bone graft that has been packed is a corticocancellous allograft. And this is the final stage at the end of the treatment of 9 months of antitubercular treatment, right? So this is the preoperative MRI and this is the postoperative MRI. So you can see that the cord has been tented by the abscess. Now the deformity has been corrected and fused posteriorly as well as anteriorly, and the cord looks intact in the final follow-up MRI. Right, so that brings us to the last slide of the presentation. So, sir, can questions now?
Please go ahead. If you have got some questions, you can ask. I have got some questions. I will also ask.
Right, Vignesh, how do you follow up a patient who has been started on antitubercular treatment?
Sorry, sir.
How do you follow up a patient? So, what antitubercular drugs will you give? How long will you give? And how do you follow them? How frequently do you see the patient? And when you see them, what will you check the patient?
We should start 2 months of HRZT.
Mm-hmm.
Then the current recommendation tells plus the 7 months of rifampicin and isoniazid for 7 months later on.
Actually, the latest recommendation purported by Dr. Anil Jain, which has been accredited by the WHO also, he has suggested the use of ethambutol also in the continuation phase. So, for 2 drugs, they have prescribed 3 drugs to be given. So that's for a total period of 7 months. And at the end of 7 months, if there is a suggestion that there is a clinical and radiological presence of tubercular infection, still we need to continue for further 1 year total. Right? So in particular, when you're treating a child, so is there anything you will specifically look when you give these medications?
Clinically, the patient will have weight gain, sir.
No, I'm asking about a child with tuberculosis. You are giving anti-tubercular treatment.
Okay, sir.
So will you skip some drug or will you specifically ask some information compared to an adult? Right. So you should be very careful in prescribing ethambutol to a child, right? So what is the most important side effect of ethambutol? Right. Ethambutol can cause optic neuritis, right? And is the first symptom of optic neuritis, the child will develop a color blindness, right? So if it's an adult, so adult can also develop color blindness, but they'll be able to tell it immediately when they start developing the problem, whereas the child will not be able to tell it as a problem. So the optic neuritis progresses till it becomes irreversible. So when you're treating a child, you should check the intelligence of the child, whether the child will be able to tell it as a problem. So if it is a too young a child, less than 10 years, you never prescribe ethambutol, you skip it in the regimen. Whereas if the child is reasonably big and able to communicate well, then only you prescribe ethambutol. That's one thing, right? And we follow the patient every 2 months. So we take radiographs to assess clinical healing. We check the ESR and the liver function test to see whether the infection is getting controlled and whether the medications are causing any hepatotoxicity. At the end of 9 months, the complete healing of the disease is based on return of all the blood parameters, all the ESR, CRP, everything should be normalized. X-ray, you should be able to see the healing of the bone. Third thing is clinical well-being of the patient. The child would have put up weight and feel much better. There will not be any pain. And last thing is you have to take an MRI. MRI only will confirmatorily tell that the infection has healed completely. Right. Was it clear?
Yes, sir.
Right. Yeah. So as Dr. Rishi, you have done, you got something else?
Yes, sir. I'm done, sir. Thank you.
Okay. Yes. There are some more questions I would like to bring up.
Yes,
during palpation, the importance of looking for spinous process widening, like in this child, the interspinous widening, we have looked for tenderness, supervision, and deep. Looking for the interspinous alignment, either in rotation is the malalignment or there is any kyphotic interspinous widening. This will give us some information. And as far as this painful and painless deformity, we have mentioned. And in this context, the differential diagnosis for painless deformity is, it goes through our mind, is whether it is something to do with congenital or idiopathic or kyphoscoliosis. Where painful is deformity is mainly with pathology involved, underlying pathology. It can be infective, inflammatory, or tuberculous type of etiology.
Yes, sir.
Yeah. So the thing was, in tumor, I just thought, what about the possibility of something like in this pediatric age group where there is a eosinophilic granuloma sort of a pathology? But should we think in this child?
Right. So eosinophilic granuloma, very, very rarely one will present with a neurological deficit. Usually the child can have a small focal kyphosis because typically it affects only one vertebra.
Yeah.
And the main complaint will be the pain. So one particular region, they complain of pain. And when we get the X-ray or the MRI, it will show a vertebra plana, which is actually well treated with conservative management. They will not present with neurological deficit.
Okay. And one more question is regarding the biopsy. So should we tell for students to tell biopsy before surgery or they might as well accept the biopsy, intraoperative biopsy in the child this age group.
So in patients whom you think that can be treated by a middle path regimen, it's always preferable to get a biopsy before starting the antitubercular treatment. So it is important for two important reasons. So even though in many patients we think that MRI wise it is a classical spinal tuberculosis, when the biopsy comes, I have seen patients who had a carcinoma of the lung. So it is a secondaries in the spine. So that could be missed if we continuously treat them with antitubercular treatment. Second problem is we have patients who have drug-resistant tuberculosis, even though the incidence is less, not very common. But still, if you get a biopsy and send it for culture, and if you are able to grow the organism, it's a important thing for the patient. So always before starting a middle path regimen, try to get a biopsy. But if you think the patient needs a formal surgery, as in this patient has a neurological deficit with spine at risk signs, then at the time of surgery, you can send the biopsy.
Very well answered, Dr. Rishi. And I just want to summarize that the way you have taken is based on the anatomy, you have told the diagnosis. You have, based on the pathology, you have discussed the diagnosis. And you have involved the neurology, whether it is you have ruled out whether it is upper motor or lower motor type of pathology. So and in addition, I would just my thought is you can also bring out whether it is a stable or unstable spine based on somebody who is able to bear load, weight, or something like that is my thought. So for the 4 different aspects, which I think when somebody is going for the exam must cover, if I put the diagnosis, whether it is stable spine, neurologically involved, or infective, or such anatomical as well as pathological component must be told when completing the diagnosis.
Yes.
Yeah. So well done, Dr. Rishi.
Yes, thank you.
If all the postgraduates are happy with the discussion, we would move on to Professor Thirumalai Murugan's presentation.
Sir Karunakaran sir, you please share your video, sir.
Share my video. Yeah, there is a problem with my.
Okay, sir. Okay, no problem.
Okay, yeah. I may be seen in another screen. Maybe I think. Yeah.
Okay.
Sir, I think you have disabled your video. Computer settings I think you have disabled. Maybe you have disabled your video.
Oh, I see. I don't know, but
maybe. Okay. I think your video got disabled. That's the problem.
Okay.
Sir, doubt. Just one doubt.
Yeah.
Sir, Dr. Rishi, just one doubt I need from, I think, basic doubt from postgraduates. You asked whether it has to be treated surgically or medical management. And do you always expect them to say about the spine at risk signs, or there is a progressive neurological problem? If a patient is having such a neurological deficit, and there is a huge abscess which is impending there. So do you expect them to say spine at risk signs and then answer that it is a surgical, or directly you can go for surgical management? Do you, because it may be a little difficult for them to remember the spine at risk signs, just like that.
So
always.
Yeah. So there are 2 things to that. If we are treating considering this is an adult patient who has a neurological deficit where the power is grade 2 to 3. There are people who still treat these patients with medical management. They give antitubercular treatment, and if such an examiner comes, then the candidate may feel that he has told the wrong answer. But spinal at risk signs is like a cauda-equina syndrome. It's like an absolute indication to do surgery in a patient with spinal tuberculosis. So if they say that first, especially if the patient is a child, then nobody is going to question their answers. But in the presence of a neurological deficit, especially if it has been found to be a progressive one, then better to do surgery.
Yes, sir. Yes. I think they have to know the spine at risk signs also. I think the message is that better they learn the spine at risk signs, so they are not at risk.
Yes.
Yeah. Yes. The correct thing. And the other thing is though there is neurology, it doesn't mean always operate. There is a role for antituberculous treatment with which they respond well. Still, the neurological recovery can happen. So, when there is neurology, it does not always operate. Yeah, that's also
okay. So I think the message is very clear, sir. Okay.
Yeah. Okay.
Thank you. So we can proceed, sir. We can proceed
to Professor Thirumalai Murugan, sir. Yes, Professor Thirumalai, you can start. The concerned PGs, please be ready.
Guna and Narendran. Guna.
Sir, yes, sir.
Guna.
Am I audible?
Yes, sir.
You are audible.
Okay.
Please start.
Okay. Thank you. At the outset, good evening to everybody. At the outset, I would like to thank Professor Thanapan and Professor Thirunarayanan for inviting me to this TNOA teaching program. And also I thank TNOA for organizing this wonderful session. And basically, I would like to share my clinical experience in spondylolisthesis, as the topic was given to me, a clinical scenario of the spondylolisthesis. And this is the institute that I have been graduated, and this is the old building, and this is the new building, the trauma care center, which caters around 300 beds. And now it has been taken for COVID ward. Hopefully, we'll get it shorter period, and we'll come back to this ward. And as the topic given me is a clinical scenario in spondylolisthesis, I would like to share my clinical case scenarios. And the most important thing is that the spondylolisthesis is a very, very important topic for postgraduates as far as an exam point of view is considered. Most of the exams, they will ask us a long question. And the theory part has been very well discussed by previous speakers in the TNOA teaching program by Dr. Balasubramaniam a few weeks before. So I thought I would skip more of theoretical aspects, and the practical aspects is very, very essential, as the bread and butter of an orthopedic or spine surgery is a back pain, and most often they present with a spondylolisthesis. So my idea of talk is that every postgraduate must be able to understand the concept of spondylolisthesis, how to analyze a case of spondylolisthesis, and what are all the ways a listhesis or lysis can present. So I would be happy that a postgraduate is able to understand at the end of the talk with these basic concepts. And we have eminent speakers like Dr. Karunakaran, who is a senior spine surgeon, and Dr. Rishi from Ganga Hospital, who has vast experiences in treating these complex deformities. And I would like all the postgraduates to interact with these sessions so that it will be useful for you, and you can ask whatever questions and we can give answers for you. So as you all know, it's degenerative spondylolisthesis is defined as an anterior displacement of one vertebra over the adjacent vertebra, and it is associated with a disruption. Here in a degenerative spondylolisthesis, there is no disruption in the vertebral limb. This is very, very important. Whereas in an ischemic spondylolisthesis, it is caused by an abnormality in the pars intra-articularis. And basically, there is a structural discontinuity between the middle and the posterior columns of the spine at the level of pars intra-articularis in a ischemic spondylolisthesis. As we all know, the spondylolisthesis is defined as a forward slippage of one vertebra on its adjacent caudal segment, whereas spondylolysis is a defect in pars intra-articularis. And one should know these terminologies because these are very commonly asked in exam as well as in theory part. And spondyloptosis is a complete or 100% slippage of the L5 over S1. So these are the basic terminologies in a spondylosis, and some other basic things PG should know is what is a pars intra-articularis, which is very commonly asked in exam, and it is a portion of the bone between the superior and the inferior articular process, and is the thinnest part of the neural arch, where most of the pathologies in the ischemic or other type of spondylosis occurs here in the pars intra-articularis. And one should know what is a neural arch, which is the bridge of bone formed with the posterior elements of the vertebra that surrounds the spinal cord. And a facet joint means it is the junction of the inferior articular process of the capsular vertebra and the superior articular process of the caudal vertebra. And one should not forget what is the spondylosis means. It's basically a degenerative changes of the spine. So one should be able to differentiate these terminologies: a spondylosis, a spondylolysis, and a spondylolisthesis. There are various classifications, but these classifications are very commonly followed. They will say Magnum and Newman classification is the commonly used classification. It is based on the etiological and topographical criteria. The Mayer classification is based on the degree of slip, and the Marchetti and Bartolacci is based on the developmental and dysplasia aspects. And the recent classification, the spinal deformity study group, SDSD, it is a little bit complicated. So I think once as you know all these classifications, then you can go into this spinal deformity study group classification. It's based on the pelvic balance and treatment guidelines classification. And this is the Wilson-McNabb classification, and is based on the 6 types. The type 1 is the congenital type, which is due to a dysplastic abnormalities. And Narendran, can you say what are the common dysplastic abnormalities we see in the congenital type of spondylolisthesis? What are the common dysplasias you are likely to see in a congenital dysplasia? Narendran, are you audible?
Sir, yes, sir.
Can you enumerate what are the common dysplasias you see in the congenital spondylolisthesis or dysplastic spondylolisthesis? In what areas you should look for?
Sir, vertebral body, sir. Case of hemivertebra or spina bifida, sir.
Okay, this what you said is mainly for a congenital kyphosis or congenital scoliosis. Now we are talking only about a spondylolisthesis, congenital or a dysplastic spondylolisthesis. We can look for abnormalities in the sacrum, abnormalities in the facets, abnormalities in the pars intra-articularis. Can you enumerate any dysplasias in the sacrum? What will be the shape of the sacrum? Okay, we'll go back once I show the X-ray. So basically there will be some dysplasias in the sacrum. The normal shape of the sacrum is lost in a dysplastic, where you can have a rounded or a dome-shaped sacrum, and there can be abnormalities in the facet joints. The facet joints is the superior articular facet or the inferior articular facet, where you can have a dysplasias of the facet joints, and the pars can also be elongated. So these are the common dysplasias which we encounter in a dysplastic type of abnormalities. I will show in the subsequent slides. The isthmic type, it is subdivided into 3 types. One is a lytic or a stress fracture because of repeated stress, particularly seen in a gymnastic or a sports persons because of hyperextension mechanisms or because of excessive bending. They are likely to have a stress fractures, and that is called as a type A. In type B, we have a healed fractures. It can be elongated. Sometimes an acute high energy fracture can also produce a isthmic type of spondylolisthesis. It is called as a type C. And the type 3 is a degenerative spondylolisthesis, where the basic problem is a degenerative disc disease. It can lead to a segmental instability and can produce a degenerative spondylolisthesis. The type 4 is a traumatic, where there is a high energy valence can produce a fracture of the posterior elements other than pars, like your superior articular facet or inferior articular facet, and that can also lead to a traumatic spondylolisthesis. And type 5 is a pathological, where some pathologies, particularly malignant lesion, lytic lesion, or infective foci in the posterior elements, or Paget's disease, all this can cause a pathological spondylolisthesis. And the last one is iatrogenic, caused by a surgical excision of the posterior elements, wide excision. So whenever you damage the pars intra-articularis during a laminectomy, or whenever you are damaging the facet joints during a laminectomy, then that can produce an iatrogenic spondylosis. So this is a very, very basic classification of spondylosis. Everybody should be able to understand this. So with these basics, we would like to go to the case scenarios. A 45-year-old male presented to us with an acute onset of back pain. So you have to be very careful in taking elaborate history. So as far as postgraduate is concerned, you must be having a very good history taking, because almost 60 to 70% of our diagnosis can be made in a proper history taking, and the remaining 30% can be done with a radiological imaging. So you should spend some lot of time in going into the detailed history. You should put some leading questions. So these are very, very basic part of a PG teaching. So this patient presented an acute onset of low back pain with 1 week duration only, and the pain started following a trivial fall, and there was no leg pain at all, and the pain is more during a sitting posture. So the posture is also very important. And the patient doesn't have any previous history of back pain and is totally asymptomatic till now. The only positive finding is there is a tenderness in the coccygeal region, and the straight leg test is negative on both sides. So this is the clinical scenarios, and you can see the clinical photograph. The patient is having good lumbosacral spine movements, and lumbosacral movements are also pain-free. So what would you like to do? What would you like to order next? Gunasekaran, can you tell me?
Dr. Professor Thirumalai, what is it the postgraduate would suspect? What is it will go through his mind? What are the things he would think of at this stage?
Yeah, this patient, the basic thing is that you must ask a proper history. So till date, the patient is not having any previous history of back pain or asymptomatic till now. And
what does Dr. Gunasekaran think, sir? What is Gunasekaran's thought process?
Gunasekaran, can you tell me?
Sir, any fracture in the coccyx region, coccydynia?
Yeah, okay. Good. So what is the next most important thing you want to take is an order an X-ray. So in the X-ray, we are able to see this picture. Can you read this X-ray, Gunasekaran?
Sir, plain X-ray showing a lumbosacral region lateral view, sir.
Okay.
There is pars fracture in the pars region.
So you feel this is a traumatic spondylolysis?
Okay, you want to say if this is a traumatic spondylolysis?
Yes, sir.
Okay, then what is the reason for the narrowing of the disc space? Can it occur in a traumatic spondylolysis? And you see there are a lot of sclerosis in the facet in the pars also, which means this is an acute fracture or it's a chronic problem.
Chronic, sir, degeneration.
Okay, this is likely to be a chronic problem because there is a narrowing of a disc spaces here, and you see there are a lot of sclerosis in the pars intraarticular area. So can you say that this can be the cause for the pain in this particular patient, or you want to exclude something else? Can this traumatic or acute pain can radiologically present like this, or you want to go for some other diagnosis?
Sir, want to see whether he's having instability, sir. To take a flexion extension views.
No, Dr. Gunasekaran. In this context, he had a fall, and you can see that you can look at his movements are full, painless. Tenderness, there is no tenderness on that particular spot. Now your focus is getting diverted towards old pre-existing pathology. You want to still continue your focus on an old pre-existing pathology, or do you think it is a fresh pathology?
Due to coccydynia also.
So that your clinical diagnosis is somewhere in the coccyx is the pain.
Was for a coccydynia, but once you see X-ray, you are getting deviated. So this is the classical way of an asymptomatic lysis. Most of the time, the spondylolysis is an incidental finding. So that's what I want to stress here. So in 90% of the patient, 80 to 90% when you review literature, the lysis is an incidental finding. So we have to always correlate clinically, and then we have to correlate the clinical and radiological imaging. So this patient doesn't have any previous history of back pain and is asymptomatic till now, and the patient had a recent onset of pain following a trivial fall. And the pain is more during the prolonged sitting, and there is a tenderness in the coccyx region. So as you said, that patient has a typical coccydynia. So we did a MR. So these are the two things. Lysis or listhesis will be symptomatic for a prolonged duration, and we did a CT and MRI. Can you see in the CT what is the finding? Gunasekaran, you concentrate on this region. There is a sacrococcygeal disruption or a sacrococcygeal dislocation. So always don't go by pre-existing X-rays, always seeing a lysis, don't fix the cause that this could be the cause for the pain. So always rule out other causes by a judicious clinical examination. So this is what I want to stress in the first clinical case scenario.
But surprisingly, the pars defect is not there.
Yeah, this is a cut which doesn't include that particular region. So the pars defect is a midline cut. Probably if it is a parasagittal cut, I think I have not shown for time being. So if it is a parasagittal cut, then it is could have been we could be able to pick up the light lesion. So this is a midline cut. I think you are not able to pick up a lysis in the CT scan. Anything you want to add, Karunakaran sir?
No, sir, I'm fine. Thanks.
Okay, so I want to stress here is that always don't go. The list lysis and lysis most of the time is an incidental finding, and we should always look for other causes if your clinical and radiological finding is not correlating. So coming to the case scenario 2, this is a 70 years old female who presented with a back pain and both leg pain for a period of 6 months. And 6 months before, she had a trivial fall and she was treated elsewhere with some conservative modalities of treatment was done. And at the time of presentation, the patient was having a difficulty in walking. And the attenders and the patient says that whenever she walks, she had some frequent falls. She had some gait disturbances. And the straight leg rising test was negative. There is no lumbosacral tenderness. And on examination, the power in both lower limb was 4/5. And other examination revealed that there was a brisk reflexes in both lower limb, and plantar was extensor and bilateral, and ankle conus was present on one side. So this is a second clinical scenario. And
Dr. Thirumalai, 1 minute.
Yeah.
Yeah. Can I ask Dr. Narendran, where would you put your diagnosis? Your basket contains of inflammatory, traumatic, neoplastic, trauma, degenerative. Where would you put your pathology now?
Sir, since it is a old 70 years old female with a chronic problem, I would like to pertain it to the degenerative first.
So history of fall, following which 6 months, and after that only the problem seems to have arise. 6 months back pain with both leg pain and history of fall.
Due to trauma.
This what do you feel like? It's a trauma induced or pre-existing problem flared up with trauma?
Pre-existing cause which was flared up after the trauma, sir.
Okay. And you think this is something neurology is an upper motor type of neurological problem or lower motor neurological problem?
Since it has a plantar extension and a clonus, it is upper motor neuron science deficiency.
So
it could be a myelopathy was pre-existing.
So lesion you are thinking is somewhere around about D10, that is the level you are thinking based on this clinical picture.
I said due to human lesions.
Like both lower limbs are weak, and are upper motor
with bilateral involvement. Yes, sir.
Yeah. So your thought process based on this should be, I think everybody would agree, but your thought process should be for this sort of a clinical picture must be somewhere in the cord level, not at the root level.
Yes,
yeah, please go ahead.
Yeah, that is exactly I want to here to stress. So we have to have a very good detailed clinical examination, the thorough history taking, and now our mind is prefixed at a lesion in the cord. But this is the X-ray since the patient had a fall, and an X-ray was taken in the lumbosacral spine, and an MRI limited cuts. So here was taken, and there was what are the findings you can say? And it reveals that there is some listhesis at the level of lumbosacral spine and listhesis and MRI also. So can this picture correlate to our clinical picture? Is the radiological picture correlating to a clinical picture?
Not at all.
Yeah.
No, sir.
Yeah, that's what I want to see. So the clinical picture doesn't correlate to radiological picture, means then we should evaluate the other causes of back pain. So this was not done elsewhere, and the treating surgeon, considering that this as the cause for pain, has gone for a decompressive laminectomy and a posterolateral fusion. And postoperatively, the patient had no relief of her symptoms, and the neurological condition started gradually worsening from 4 to 3/5, and preoperative symptoms also started worsening. So this is what I want to stress here, that you should always correlate your clinical and your radiological findings. And most important thing here is I want to stress that, as Rishi said in his talk, that you should always have a whole spine MRI. So the problem in this particular case is that they are not done a whole spine MRI, and here the listhesis is an incidental finding. So when we did a whole spine MRI, and the clinching point here is that the patient had a difficulty in walking and frequent falls. And as you said, the reflexes are brisk in both lower limbs. There are human signs. Then this condition for listhesis is unlikely to produce a human signs. And the frequent falls, all these things are very uncommon in a listhesis. So when we did a whole spine MRI, so this is the radiological picture. Can you, Gunaseran, now can you say what is the clinical picture as you can see in this particular patient? Can you say it's a traumatic cause or a degenerative cause?
Dr. Gunasekharan. Yeah.
Dr. Gunasekharan or Dr. Narendran, anybody can answer.
It's a 70 years.
Sir, it is a T2 weighted image of spine lateral lumbar spine, the lateral view, showing a collapse of the vertebral body with retropulsion of the fragment, which is causing cord involvement, and then with disc space narrowing and
disc space narrowing.
Disc space, how we
disc space is
this is vertebral body. This is the disc space. This is another vertebral body, and this is your
disc height. Disc height is well maintained, actually. Yeah.
Okay.
Can it be an? So you want to say it is a? What is your clinical radiological? With this radiology, it is a traumatic.
It could be due to inflammatory cause, like collapse, not due to trauma.
So basically, it's very radiology into traumatic cause, an infective cause, or a tumorous cause, or a degenerative cause. So these are the common problems in a spine which can present with a neurological deficit. Okay, this is
due to infective destruction.
This is not destruction, Dr. Narendran. This is a fracture. This is a traumatic fracture with the displacement of the fragment with well-maintained disc height.
So what is the basic difference between an infective foci and a traumatic foci? How will you differentiate? Can it be an infection?
T1 and T2 images are.
What is the first earliest sign in an infection? What will happen to your disc space? In a tuberculosis or a pyogenic spondylolisthesis, what will happen to the disc space? So there will be a narrowing of the disc space in case of an infection. So this is the first and foremost sign will be a narrowing of the disc space in an infection. So I think you have to be very clear in this. Whereas in this scenario, there is no narrowing of the disc space. So the possibility of an infection is unlikely. So here there is a vertebral body collapse is there, and there is some retropulsion is there, and the patient is around 70 years, the whole spine is osteoporotic. So this is an osteoporotic compression fracture. Okay, basically it is a pathological fracture. The pathology here is an osteoporosis. So sometimes in osteoporotic fractures, you can have a neurological deficit because of the retropulsion of this particular fragment. So ultimately, to summarize is that always you take a whole spine MRI to rule out other problems when you have a human signs in the lower limb, and a patient with a listhesis or lysis will not present with the human signs in both lower limbs. So after making a diagnosis of a compression fracture with retropulsed fragment, osteoporotic compression fracture as well, then we did a decompression and a vertebroplasty, and the patient started showing improvement in her neurological status. So these two scenarios I want to highlight that almost when there is a patient, you see an X-ray, you can say that almost 90% of the patients are asymptomatic. A case of a spondylolysis or a spondylosis, 90% is asymptomatic. Only 10% is affected with symptoms like back pain, axial low back pain, or maybe associated with a radicular component. So after these two case scenarios, you must be able to understand that we can see a lot of patients with the asymptomatic lysis and listhesis. So don't ever treat radiology, always treat the patient. Karunakaran sir, you want to add, or shall we proceed?
Yeah. As you rightly pointed out, the clinical examination findings must be correlated with the image. So your diagnosis is almost established during your clinical examination. So the confirmation is only by an imaging. So you should have suspected a pathology as a traumatic pathology in this case, and as well as the neurology would tell you which level the cord was compressed because of the upper motor signs. And of course, the patient has been having pain, which is been existing with a slowly progressive. So it means that there's an inherent pathology which is like poor quality bone or pre-existing degenerative problems would have contributed to this sort of situation. So we had earlier told, you must have the anatomy, you must know the neurology, you must know the pathology, and whether stable or unstable situation when you're given diagnosis. Yeah, please proceed, Professor.
Okay, thank you. So coming to the next case scenario. So this is a 15-year-old boy who comes with the complaints of the mother is the informant, and he says that child நல்லதா இருக்காங்க சார், but அப்பப்போ ஒரு முதுகு வலி மட்டும் சொல்ல. So occasional mild low back pain for a period of 8 months duration. He is able to perform his day-to-day activities like going to school, able to walk, able to jog, able to do his day-to-day activities. And occasionally he says after a period of prolonged exertion, he says that there is a mild back pain. So this is one of the important history this patient has come with that complaints. And the mother also says that this patient was walking like this with the knees slightly flexed. Sorry. And on examination, and this was the clinical picture, and there is no classical sciatica or a neurogenic claudication in this particular patient. And the straight leg raising test was 70 degrees bilaterally. And can anyone proceed what is your clinical diagnosis for this patient?
Gunasekaran?
Sir, having patient having
Is the patient is having only a mild back pain, not a very severe back pain, which limits his day-to-day activities. Having only mild back pain, particularly after prolonged period of exertion. And the most important thing is that the mother says this patient is walking with his knees slightly flexed. This is a very characteristic finding in this particular clinical scenario, which we will discuss in future slides.
Yeah, 1 minute, Dr. Gunasekaran.
yes.
Can you just describe this exactly what is happening? What is the attitude of this patient?
Patient having exaggerated lumbar lordosis.
Yeah, good.
Flexion at the knee, and it's due to hamstring contraction.
No, I didn't ask you. Please excuse me. Yeah, whatever you see, observation, you tell me. Then we would ask what is happening. Is it okay?
Yes.
Yeah, please tell me.
And protrusion of chest cavity is continuing.
Okay. You feel the chest is protruded. Okay. What about looking at this gluteal area? What is there anything significant there? It's got almost a flattened, not a flat back with this. Sorry.
Wasting of.
It is because this is actually not wasting. It is because of the tilting of his pelvis. His pelvis is not anteriorly tilted. It is now slightly retroverted. The pelvis is retroverted. That is why you have this. They usually say this has a heart-shaped sacrum, right? This looks as a flat sacrum. It is usually not. Usually the tailbone becomes more prominent. Here you see the sacral, major part of the sacral bone is more prominent here. Okay. Is there any sign which you will tell for this sort of attitude?
A classical sign, as rightly pointed out by Karunakaran sir.
Phalanx-Dixon sign, sir.
Good. Yeah, that is Phalanx-Dixon sign. What is Phalanx-Dixon sign?
Sir,
the hip and knees flexed. Okay, that is most all these signs. This sign is the classical. The posture is the classical Phalanx-Dixon sign. In which condition you are able to? Phalanx-Dixon sign is present in which condition?
Spondylolisthesis, sir.
Good. Which type of spondylolisthesis? Are you able to see in all types or in particular subtype? Okay, we'll go to the subsequent.
Yeah, Dr. Narendran earlier wanted to explain something. Now is the time. I think you can explain what is happening, what is the mechanism happening, and why these things are happening. Mr. Narendran, Dr. Narendran, can you tell me? You started talking about the hamstrings. Yeah.
Sir, actually, patient is walking in a flexor posture, sir, so that the canal diameter is increased, so making the stenosis is relieved, and patient has perceives no pain, sir. And since there is no straight leg raise synthesis 70 degree and patient has no sciatica, there is no root problem actually in these patients.
Yeah, you're right. But the point is, this patient has got a tight hamstring muscles, so that is why it is not allowing the pelvis to be anteriorly tilted. It is posteriorly pulled and is also so tight. It is also causing the knee to bend. All this contributing to the forward slip and as well as the loss of the body balance.
Okay.
So, shall we proceed?
Yeah, Prof. Proceed.
As you said, this is the classical Phalanx sign, which is seen in a congenital spondylolisthesis, and this is mainly the hamstring tightness is all because of the irritation of the L5 nerve root. That is why constantly the child keeps his knee flexed. That is the only presentation in this pediatric age group will be a hamstring tightness. So whenever a child comes with a back pain with this particular type of posture, and you should always look for the tightness. So that is the only positive finding will be able to elicit in this particular type of spondylolisthesis. Because when you see this X-ray, you see this is the gross abnormality. You see such a huge deformity is there, but clinically the only finding will be a hamstring tightness and a mild low back pain. So I want to stress that you must be able to always pick up this finding in a pediatric age group with such type of Phalanx sign. You must be always able to elicit the hamstring tightness. It is mainly because of the L5 nerve root. Now you can say what are the findings, common findings in the this is the congenital spondylolisthesis. In the first slide, was what are all the dysplasias you will see. Can you just enumerate?
There's dysplasia of facet joint.
Dysplasia of the sacral slope. What has happened to the sacral slope? The sacral slope has gone for it is a dome shaped. It is a dome shaped sacrum or a rounded off sacrum, and the sacrum has become more vertical. There have been some dysplasias in the facet joints. The plastic anomalies, these are the common dysplasias. The dysplasias of the facet joint and dysplasia of the sacrum. Sir Karunakaran, sir, you want to add anything?
In addition, the vertebral body, the trapezoidal vertebral body is also another contributing factor. This yeah. Please proceed, Dr. Thirumalai.
Yeah, clinical examination. So this is the classical Phalanx sign where the child walks in a hip and knees in a flexed position. And on examination, you are able to see the vertical sacrum and pelvis. And there is a junctional kyphosis. There is a lumbosacral kyphosis here. And another important finding is there is a hyperlordotic lumbar spine. And the child walks with a waddling gait, mainly to balance his pelvis and leg. So this is the MRI showing the high grade or a spondyloptosis picture with irritation of the lumbosacral nerve roots. So that is the classical reason for his hamstring tightness. So whenever in a dysplastic or a congenital disease, always look for these findings. There's a hyperlumbar lordosis, a lumbosacral kyphosis, and the hamstring tightness generally presents as a flexion contraction of the knee joint, and there may be a transverse law increase, and the patient typically walks with a waddling gait mainly to balance the pelvis and knee joint. So what I want to stress here is that the clinical picture is very, very mild. So unless otherwise you have a intuition or unless otherwise you have a thinking that there should be a congenital spondylolisthesis, you are likely to miss this clinical condition, because once you are not able to treat it at an earlier stage, then this listhesis is going to progress severely and the patient may end up in a severe complications. And when you diagnose is late, then it becomes very, very difficult for us to treat this condition, because the deformity is very complicated and it becomes very rigid. So the take home message at this slide is that you must be able to diagnose this condition very early and you have to start treating it appropriately.
Yeah.
Sir, anything?
There was one question whether these children have got very long arms, whether it is like morphonoid features. but actually it's not marfanoid features. It's because of the truncal shortening. You see that the rib is almost hitting the iliac crest and the bones are all slipped forward. It looks like the arm has a long length. It is actually not marfanoid features actually. Yeah, that was a question I could see in the chat box.
So this is because there is a narrowing of the costocrystal distance. So that is one of the clinical examination we see in a spondylolisthesis. The distance between the rib and the iliac crest is diminished. That is the another important clinical finding we should look for a listhesis patient. Okay, we'll proceed to the other case scenario. The other type of presentation of a spondylolysis or a listhesis. A 30 years old male, they presents only with a low back pain and there is no leg pain, and for a period of around 6 to 8 months the patient presents with symptoms and is not responding to a conservative treatment, and the spine movements are painful at the extremes, but there is no root or stretch signs. Root stretch signs is not seen. The SLR is negative and there is no radiating pain or a neurogenic claudication. So this is the X-ray. You can see. You want to tell anything? Narendran, can you read the X-ray and tell me what are all the findings there?
The X-ray lateral view mature patient showing lumbosacral junction with a slip rate of L5 over S1 with a pars intra-articular defect with the facial joint arthritis with slip rate and
okay, since this is classical lytic listhesis, okay, lytic, this is spondylolysis, there is not much of listhesis there. You see a defect in the pars intra-articularis, this is your superior articular facet, and this is your inferior articular facet, there is a defect. So this is your pars intra-articularis defect, this is a lytic listhesis. So most of the times, you may not be able to have such a classical lytic picture. So do you want to order some special X-rays if you suspect a lysis and you are not seeing it clearly on a lateral view? You want to order a special view? What special view will you take?
I would like to add a flexion and extension view of the lumbosacral.
Okay, flexion and extension view is mainly to look for
instability of the fragment.
So you can
and I would like to look at oblique view for.
Yes, you should go for an oblique view if your lysis is not clear, but you still suspect a lytic lesion. You should go for a oblique view. What is the thing you will see in the oblique view? Any sign?
Sir, we look for a beheaded Scottish dog appearance.
Scottish dog sign. And what are the one thing which you commonly ask in the exam is what are the parts of the Scottish dog and what are the parts of your oblique view? Can you tell?
So the ears are superior facet is formed. Yes, sir.
So this is your
superior.
Yeah.
Eye of the
eye corresponds to your pedicle.
Pedicle
of your Scottish dog corresponds to your pedicle. Just a minute, I'll just. Sir, Karunakaran sir, you carry on. I'll just put on the plug.
Yeah. So please go ahead with your description. So the pedicle is the
pedicle that denotes the eye of the neck, and the nose is formed by transverse processor, and the ear is formed by a superior articular facet of the upper vertebra. And then neck is formed by the intra-articular defects there.
Okay.
And the inferior articular facet is forming the front legs, and the posterior, the behind legs is formed by spinous process of and the inferior facets.
Okay. Here, and this patient, I think if you could quickly recollect, is just present with back pain, and it's got no neurological symptoms, and is in his clinical history. Or in your clinical examination, what would you ask or look for? Many people tell you back pain, but is there specifically which you would, when you want to examine this patient, you look for? Because now you know that there is some sort of a mechanical problem. What is that you will ask for, and what will you look for? See here, the one thing which you have to ask for is the gravity of the situation. How much of disability is he experiencing because of his back pain? is this day-to-day routine is being affected. So you know that how severe is this problem, and what you have to look for is an extension catch. When you when they are moving, you have to look for extension catch.
Sir.
Yeah, can you tell me how do you look for an extension catch?
Sir, sorry, I don't.
Gunasekaran, can you tell me what is an extension catch?
No, sir.
Okay, Dr. Narendran.
Sir, sorry, sir, I don't know.
Okay, Veeramani. Okay, the extension catch is basically when you ask the patient to bend or to reach his toes and come up. There will be a pause. Then there is no smooth returning back to the normal standing position. There will be a pause, or they try to take a support of the knee or come up. That sort of a movement means that there is a catch, extension catch. They are not able to move in a very synchronized manner. They will have a pause and then come up. If that sort of is there, then it is clinically relevant, and that sort of an instability pain is there. And in history, again, you can ask that if they wear a belt, if they feel that there is a significant pain relief, then there is a with a brace or a belt, if they tell a significant pain relief, then also you can suspect an instability component. Yeah.
Okay. This ROI is called as a extensor leg raise testing, which I will show in subsequent slides. The last few slides, we will have a clinical picture of that particular extensor catch diagnosis. So this was the previous case scenario. So most of the time, a lytic listhesis will present with a back pain alone. There are not much of a leg pain. So one should not think that always a listhesis and lysis should cause a back pain and a leg pain. So it can present as the congenital listhesis, it can present the mild symptoms, or lytic listhesis can present with a back pain alone, or the other part, the last case scenario, it can present with a severe neurogenic claudication. So this is a 60-year-old female who complains of severe both leg pain, and the back pain is very mild, and the classical symptom here is a severe neurogenic claudication, and the walking distance is becoming reduced gradually.
And can somebody, Professor Thirumalai, just a quick question. Can somebody differentiate between a vascular claudication and a neural claudication?
Narendra?
Sir, vascular claudication is actually usually a patient consists of a cramp or tightness, sir. The walking distance gradually decreases, and usually patients feel painfully while walking downhill, sir. And the stride and the distance travel is usually decreased there. And in neurogenic pain, there is variable length and variable distance in walking, sir.
Not very clear answer, I feel. But see, vascular is, you have to say that the pain is from the distal part of the body and it ascends up, because that is where the ischemia starts and the pain starts going up. Whereas the neurogenic is going to descend down from above downwards, it is going to be there. So always when the nerve is there, it's going to have a neurogenic component where there is some pain, tingling, paresthesia. This sort of neurogenic component will be very much highlighted when you have a neurogenic claudication. So you might have weakness. All these things are more significant. Like stooping forward will cause relief of pain because the nerve space is going to increase. This sort of, with change in posture, there is going to be no change in the canal dimension. Though it changes or doesn't change, in vascular, the pain is going to still persist. So this will be a more precise way of telling the difference between a neurogenic and a vascular claudication. Okay.
Another important finding is that neurogenic claudication is most of the time is associated with the numbness and paresthesias. Whereas vascular claudication, you may not have the numbness and paresthesia. That is another important differentiating picture between the neurogenic claudication and the vascular claudication. Shall we proceed, sir? Okay. And the MRI was taken in this previous MRI still see there's a complete cutoff for this level. There's a this MR myelogram where you could see completely there's a complete cutoff, means there's a severe canal stenosis there. And in MRI, you can see that there is a canal stenosis there. Anyone is able to pick up a listhesis? Is the listhesis seen or not in this radiological imaging? Can you pick up?
Gunasekaran, can you able to pick up the spondylolisthesis with these cuts?
No, sir.
Yeah.
No. Very carefully, you can see there is a very minimal, the posterior border, very, very minimal listhesis there. So why in an MRI you are not able to see the listhesis? Rather, we will not be able to see the obviously you are not able to see a listhesis in MRI. Why?
It's a good question, actually. Yeah.
But whereas if you take a other what is the important investigation that we have missed in this particular scenario? Anyone? Any important investigation we have missed?
You have been telling for the past 4 scenarios.
So that's what I want to stress here also. We commonly do these mistakes. What is important? Imaging we have missed in this particular scenario, which I have showed subsequently. So you should always take a stress X-rays. Okay. So stress X-rays is very, very vital part of any lumbar spine examination and imaging. Always when you suspect a lumbar canal stenosis, always you do a stress X-rays. Gunasekaran, can you tell me how to take a stress X-rays? What are all the ways you can take a stress X-rays?
Flexion and extension.
Probably you take a
hyperextension.
You take a flexion extension lateral view. Okay. Sacral spine in a fully flexed. This is your fully flexed position, and this is your fully extended position. You take a X-ray. So you are able to see the translations, and this is the classical stress views you take. Is there any other way of taking any stress view? Which is also very equally efficient as good as this. Any other way of taking stress views? You take a standing lateral view. So most of the time what we take is a supine or lateral view, which is not going to stress the lumbar spine. So by doing a standing, you are dynamizing the spine, or you are putting a load into the spine. So that is what the patient complains. So most of the time, they say that when we lie down, I'm not at all having pain. When I stand, I have this typical body position. So you have to load the spine. So by loading the spine means you have to do a standing lateral view that is more efficient than this flexion extension lateral view. So it's always better you take a standing lateral view. So that is why in an MRI also, you are keeping the patient lie down, and you're not able to see the listhesis in the MRI. So most of the time, the listhesis becomes innocuous, or it is not obviously seen in an MRI. So always you have to take a stress view to locate the listhesis. So then only you can do a decompression and a fusion. So these are all the basic things I want to stress in this particular clinical scenarios. And rest of the slides I will rush up for amount of time. I think this made in classification you go through your textbooks. This SDSC classification, as said, it is a little bit difficult, as well as it is mainly meant for a later stage when you start treating listhesis. It is based on the spinopelvic balance. The spine surgeon, you can concentrate on this particular type of classification. So once you make a diagnosis, the next important question the patient will ask, sir, or what are all the problems, surgery or the treatment, you must be able to answer. So the common question the attenders will ask that if you are going to leave this, then what happens? So that means if you are not going to treat, what is the natural history? So how will this lysis or the listhesis progress? There are certain risk factors for progression. Whenever the presentation age is young, or whenever the gender is female, and when the slip angle is more than 10 degrees, and when there's a high grade listhesis that is more than 50% slip, and the dysplastic listhesis, as I said, the dome-shaped vertebra or an inclined sacrum. So all these are very high risk factors for slip progression. So if you see a slip now, and with these risk factors, and if you follow this patient, and if you see after 1 or 2 years, definitely there's a high chances that this slip is progressive. And so you must be able to intervene at this stage itself. So you must be able to identify what are all the slips that progresses, and you must be able to treat them accordingly. So the dysplastic spondylolisthesis obviously is going to have a high risk of slip progression. Generally, it is usually asymptomatic. As we saw in the first 2 slides, it is usually asymptomatic or mild symptomatic. And generally, it presents as a high-grade listhesis or high-grade sleep. And if you are not going to identify and treat, then they are going to land up in neurological complications. In a light-take listhesis, when the displacement is less than 10, when the patient is asymptomatic, the symptoms is also very and there is no back pain or it's asymptomatic, then the chances of progression of sleep is very minimal. And when the sleep is very high and the patient is having a severe back pain, then the chances of sleep progression is also very high. Coming to the degenerative spondylolisthesis, and this author has studied that follow-up of 10 years, and he has seen that there is a 34% of the patients showed progression of the sleep, but it doesn't have any effect on the clinical outcome in a degenerative listhesis. Whereas in a lytic and in a dysplastic listhesis, whenever there's a sleep progression, that means you have to take it very, very significant. Whereas in a degenerative listhesis, the sleep progression we need not worry about because it doesn't have any clinical effect on the clinical effect. So with this, I would like to summarize the clinical evaluation. Most of the time, the spondylolisthesis is asymptomatic, as you could see that it is incidental finding in X-ray. The symptoms is caused by chronic muscle spasm. They produce back pain due to a painful pseudoarthrosis of the facet joint or the pars intra-articularis. And the back pain can also be due to a degenerated disc and the tears and the annulus fibrosis. And it can also be due to facet joint degeneration and facet hypertrophy. And the pars defect, fibrocartilaginous tissues, all this can cause a back pain. And whenever there's a compression of the nerve roots, they may produce the symptoms of the spinal stenosis and they can produce a neurogenic claudication. These are all the various patients with the listhesis can present. Whenever symptomatic in a younger child or children, they present with a back pain or a particular fatigue pain during the movement of hyperextension. And the classical symptom in a congenital spondylolisthesis is a hamstring fatigue or pain due to a irritation of the L5 nerve root. And some patient may present with the sciatica. Whereas a degenerative listhesis generally present with more than 50 years of age group, and they classically present either with a back pain or a neurogenic claudication. And sometimes they can present with a motor weakness, reflex changes, and sensory deficits. And this is the clinical finding you should look for. As rightly pointed out by Dr. Karunakaran, the buttock will become flat or heart-shaped in a severe high-grade sleep because of the sacral prominence, and the sacrum becomes more vertical. And previously discussed, there is a lumbar hyperlordosis is present, and the peculiar spastic gait or the phalanx distance sign is due to the hamstring tightness and a lumbosacral kyphosis. So this is a excited lumbar lordosis, and the presence of this transverse law increase would always take these clinical findings in a patient with a spondylolysis and a listhesis. And on palpation, you always look for the step in the listhetic segment. Whenever there's a listhesis, you look for the classical step in the lumbosacral junction, and you should also look for the over the pars defect. And as previously discussed, always look for the hamstring tightness on your straight leg. This is the very, very important clinical finding one should not miss in the case of a congenital spondylolisthesis. Most of the time, the movements will be normal in young patients, and sometimes because of the hamstring spasm and the paraspinal muscle tightness, it may limit the forward bending and the deflection. And as usual, the degenerative spine, they have a stiff spine. And also look for positive nerve root signs like your motor deficit or your sensory impairment. This is a classical passive leg extension test, as rightly pointed out Dr. Karunakaran, that is the extensor catch test. You hyperextend the hip or you extend the leg, and the patient is likely to have a tenderness or a pain in the lumbosacral spine. So in a listhesis or lytic lesion, the hyperextension is likely to produce a pain. So this test is very classical of your lysis or your listhesis. So before going to conclusion, these are the various factors one should consider before taking into treatment. So what is the exact cause for pain in or the listhesis? Whether you are going to treat conservative, there are a lot of controversies regarding the decompression versus no decompression, and what are the types of decompression, instrumentation. All these are not the purview of this topic, so it's mainly clinical discussion. So we'll stop short here. So take home message is that always you correlate the radiological finding with the clinical history. as an incidental spondylolisthesis is very, very common, and we should always not treat the X-ray, we should always treat the patient. Identify the dysplastic or congenital listhesis in a very early stage so that you can intervene at that particular stage to prevent further progression. A detailed examination is a must to identify the exact cause of pain. So unless otherwise you treat what is exact, you know what is the exact cause of pain, you're not able to treat that cause. So identification of slip progress is very, very important in a high-grade lytic and a congenital type. So you have to identify very early and you have to start the appropriate treatment. And thank you. So if you have any, thanks for your discussion. Sir, Karunakaran, sir, you want to add anything?
Professor Thirumalai brought out lots of red herrings, like what is looking on X-ray a very worrying pathology, bringing out a pathology which is based on clinical examination. You have brought out very well, and it is very important. Now and then we see these sort of pathologies which we miss. We quickly go to do a quick examination without going into complete details from history, clinical examination, palpation. We look at the image, we get landed up in problems. So never do that. However busy you are, go stick to the basics. And as you said, sir, in the last summarizing slide, identifying the pain from where it is coming is very important. And in this context, I would like to ask our postgraduates, from in spondylolisthesis, let us say in lytic listhesis, from where would you expect the, let us say lytic listhesis with radicular pain, where do you think would be the cause of pain in lytic listhesis for a patient with radicular symptoms? Lytic listhesis L5, S1, and the patient has got pain radiating down the leg. Where do you think is the cause for the pain? L5, S1, where do you think is the cause for the pain to radiate down the leg? Dr. Narendran?
Due to listhesis, there may be a forward slippage, which in turn causes the disc to narrow, which compresses the nerve root and the in between discs. So, due to this compression of the nerve root, we can experience radiculopathy pain in such patients.
Yeah. So let us say L5S1, okay, level. Which nerve root would you think would be predominantly involved in a lytic type of listhesis? Let us say grade 2 sort of lytic listhesis.
Traversing nerve root S1 will be usually most affected.
Yeah. The point which I want to emphasize is more than the disc. It is the foramen which is because of the fibrosis which causes the radicular symptoms. Otherwise, it would have caused only a mechanical pain. It is the fibrosis along the pars defect which predominantly gives the radicular symptoms. And in this context, I would just ask you one question: what is pseudo disc bulge? Dr. Gunasekaran, pseudo disc bulge. Which on an MRI is not actually a bulge, which would look for an L5S1. If you look at just below the L5, it looks like a bulge. But if you look at below at S1, it would look like a normal looking bulge. So it is because of the forward slip, it looks as a bulge. If you cover the vertebral body of the S1 and see, it will look like a disc bulge. If you color the L5 body and look at the disc, it will look like a normal disc. So that is how you differentiate a pseudo disc bulge. And sources of pain would differ in different types of listhesis. Let us say an L4, L5 degenerative listhesis. Again, it can be from the hypertrophied facet joints. It can be buckling of the ligaments. It can be contributed by the disc bulge. So the different pathologies will have a different radicular problem. This is what I wanted to tell the postgraduates. And it is, I think, a well-conducted extensive discussion, more than 2 hours. I take this opportunity to thank Dr. Rishi for wonderful highlighting the clinical importance at different stages. Professor Thirumalai for briefing about the clinical significance, particularly what looks obvious on X-ray and if not matched clinically, how dangerous it could be. And thank Professor Thirunarayanan and Professor Thanapan for this wonderfully organized evening. Friday well spent. I thank all the TNOA office bearers for this opportunity.
Thank you so much, sir. Karunakaran sir, thank you so much. Thirumalai Murugan sir, Rishi sir. Both these topics are very complex topics for the postgraduate level, but it is very simple. It is presented in a very simplified manner so that they can take it to the exams. So both tuberculosis of spine as well as spondylolisthesis has been covered in a much simplified and exam-oriented manner. And all the basic doubts, I think, was put forward and got cleared in the forum itself. I think the professors get a lot from this program. I once again profusely thank Professor Karunakaran sir, Professor Thirumalai Murugan sir, and Dr. Rishi sir for allotting their time and giving their valuable input to this program. Thank you all. I also thank my co-coordinator, Professor Thirumalai sir and Professor Suresh Kumar sir, as well as I thank the TNOA president and the secretary, as well as the sponsors. Alembic, and I also thank the postgraduates who have come to this forum and presented and made the discussion very fruitful. I congratulate all of them. With this, we are going to conclude our spine session. We'll start the hip session from next Friday. Thank you all.
Thank you, sir. Thank you, all of you, sir. Thank you all for your wonderful time, especially Dr. Thirumalai, Dr. Rishi, and Dr. Karunakaran. Very, very busy people, I know. In spite of that, they have given us their time and